Let me see. So what I should say about the Brompton and also St. Thomas's, as you probably know, are major COVID centers. And we have seen the last 2 or 3 weeks a major change in our practice at our own institution, being part of the national effort to prepare and defeat this aggressive virus. So we'll come back to this. One of the legitimate concerns is how can we at the same time maintain the tertiary care that our patients need. And there have been obviously adaptations in our practice, and we are available to our patients. There are short and long-term plans. And may I say that at the end of this difficult period, which is going to take some time, our practice is going to be different from what it used to be. But that should be for better care and a better journey for the patients. So let me see. Viruses, epidemics are not something new. They've been with us over the millennia. And a most notable example is the Spanish flu that had about 50 million people dying, more than the kind of deaths of the 2 world wars. Coming to coronaviruses, there is a strain of the virus, which 3 or 4 of them, which give very mild disease. But you can see here on this editorial from the International Journal of Cardiology from last week that there were the first epidemic of SARS-CoV in 2002 that was contained. There was a second epidemic ongoing, the Middle East respiratory syndrome, which started from Saudi Arabia in 2012. And unfortunately, our world was not prepared to deal with the third pandemic that we're all faced with, which started in December of last year in China. I think the first thing to say is that the vast majority of patients have a mild illness, which is a flu-like illness. And from the data that we have, it appears that probably about a quarter of patients have no symptoms at all while they're exposed to the virus, and with time become immune. There is a proportion of patients, about 15%, who have severe disease, and only a small minority, but obviously important minority, that develop critical disease later on in the process, in the later stage. And these are the patients that require intensive care support and facilities. You see at the bottom of this green box that the case fatality rate varies greatly between places. And I think one has to question the accuracy of data sets as they have emerged. I think it's fair to say that in Korea, they were quite proactive in tracking the disease, testing, and also respecting the so-called social distancing measures. It was suggested that the Italian population is perhaps older than Asian countries, and we'll come back now with real data. I really value Massimo and Paolo being with us. These are the stages of the disease. On the left panel, you see the blue arrow, the early infection, usually with flu-like illnesses, symptoms. And for the majority of patients, self-terminating before it goes to the pulmonary phase, which usually is after 5 to 7 days, that you have more marked respiratory distress. You may have some hypoxia. And I think this is the phase that our Prime Minister is currently nursed at St. Thomas's Hospital. So a disease that spares nobody, clearly. And then a small minority of patients who may have an excessive response inflammation response, that they go into the acute respiratory distress syndrome and they're in trouble and they need full intensive care support. At the moment, the global effort is to change the first peak that you see here, the orange peak, into something which is delayed and smoother. Because if we had the first peak, let's say in the United Kingdom, despite this enormous effort at national level to prepare for it, there will be no capacity to support the vulnerable population that goes into the critical phase that requires intensive care therapy. Just not possible. And that's what we're seeing to some extent, and sadly happening in New York. So the emphasis at present is to push this smoother peak to later on allow for better intensive care facilities and more available facilities to develop, and B, in the process, to start having a significant proportion of the population immune. So the message, stay at home, is absolutely crucial, including Easter. And I think this is going to take some time. We need to be patient with it. These are the symptoms, as I said at the beginning of the exposure. Early symptoms may be flu-like, and the majority of patients would recover within a week or so. But some patients, the fever will persist, they will develop respiratory distress, and obviously they will need more attention. And some of them hospital admission and intensive care support. Some other characteristics of this new disease, as we are getting to know it, is that loss of taste and smell. Also, we see some vasculitic phenomena. Other organ involvement is not uncommon in patients with critical disease. This is data from Wuhan, the origin of this pandemic in China. And what you see here in the red box, the patients who have cardiac involvement and arrhythmias, which are common complication, which is a percentage of about 20% of those hospitalized. Clearly, the first organ that is hit by this aggressive virus is the lungs, the respiratory system. But there can be cardiac involvement. And for those sick patients, kidney failure is common. So in our very different environment at the Royal Brompton Hospital with multiple intensive care wards converted to, I would say that more than 50% of ventilated patients, it's all ventilated patients with COVID, but we do have green areas for selected patients that need admission, but those ventilated patients, many of them are filter kidney support. What are the mechanisms of cardiac injury in COVID-19? There may be direct damage from the virus through the AC receptor mechanism. It may be, as we saw in the previous graph, there is extensive pro-inflammatory surge that is affecting the cardiac myocyte. And it may also be that the patients who have very severe ARDS, lung disease, that through hypoxia, or it may be all of them. Age is clearly relevant. Older patients are more vulnerable to this aggressive disease. And in many ways, this is a relative advantage for our adult congenital heart patients because they are younger in relationship to the general population. There are younger patients affected by the disease, but and although we see very small numbers of patients dying in childhood, these are indeed very small numbers. So the vast majority of casualties from this are patients who are older than 60. And it may also be, and I think the data from Lombardy are very revealing in that sense, even for the congenital population, and the message to us all that it's not just age per se, but it's comorbidity that comes with age, such as obesity, lack of physical activity, systemic hypertension, maybe diabetes. So who are the high-risk groups? As we said, age older than 65, all the patients who are in a sort of confined space, who had the tragedy in Scotland of 13 patients dying from COVID, almost certainly in a nursing home, patients with underlying chronic lung disease of moderate severe severity, immunocompromised patients. I'll come back to this, but that includes smoking too. Obesity is a risk factor, diabetes, and some of it is, modifiable, pre-existing kidney or liver disease. For pregnancy, the data are not clear-cut, and I'll come back to on this in a moment. And the background of serious heart condition, which is the source of a lot of conflict and conflicting information that you get. So I will discuss this again, but I think the majority of adult congenital heart patients who do not have other comorbidity outside their structural heart problem, and they're not in heart failure, and they're not immunosuppressed, a very small minority maybe, are low risk with this pandemic. We somehow have a consensus that the more extreme end of the spectrum, those with a single ventricle physiology, and some of them with cyanosis, I think undoubtedly patients with pulmonary arterial hypertension, maybe patients with a systemic RV, and those with previous decompensated heart failure or cardiomyopathy. I think transplant patients, again, because of immunosuppression, and as you said, other comorbidity like kidney or lung or liver disease. A lot of consensus as to whether somebody who is on ACE inhibitor should discontinue because of this potential mechanistic link. I think the advice currently is not to change your medication unless there's a specific reason for it and after consulting your provider. The pregnancies I alluded to, there is nothing to suggest that pregnant women are more exposed to the virus, and they need to take the measures that all of us, patients, we, the whole public need to follow. There is, again, conflicting data, initially suggesting from China that there is no vertical transmission. There is some data now to suggest that vertical transmission is probable on small numbers. I would suggest that you visit the Royal College of Obstetricians and Gynecologists. Their site has a regular update, very, very informative. I think breastfeeding is not an issue, but if the mother has COVID-19, she needs to take all the precautions, try not to transmit this to her infant. That being said, infants, even those born to mothers with COVID-19, whether this is vertical transmission or peripartum, their prognosis is very good. Some advice, and this is an extract from Adrian Kovacs from the very successful webinar like ours that the American Congenital Heart Association ran last week. So I think this social distancing is a misnomer. It's a physical distancing that you need to apply. Keep about 2 meters apart from people, so to minimize the transmission of the disease. It should be embracing socially people. This is the opportunity to do a better job. And we must obviously use technology. So embrace our family, embrace our friends, embrace colleagues. So it is an opportunity. It's not social, it's a physical distancing required. I think our congenital population, their families, have excellent coping mechanisms, and they are an inspiration to us every day in our practice, being told that they or their children have congenital heart disease, subjected to multiple operations, some of them with physical disability, and uncertainty about the future, not only with this crisis in general, we're getting better, and yet having a positive outlook to life. So there are existing coping mechanisms to take you through this. I would suggest personally to limit exposure and consumption of news. I would like to see that we focus on what we can do and what we would like to learn and make better out of this period of upheaval for all of us. Having to spend more time with family in confined spaces, I think we need to be more patient and tolerant of others and of ourselves. Stay in touch with your health providers. There's a fantastic framework in the United Kingdom. There's been a lot of focus on it to make it better, but it's a fantastic network and people committed to it. So stay in close contact with them. And if help is needed, ask for it. So we must take better care of ourselves. And I know it's easy for me to say, not easy to apply, particularly for people who live in urban areas and in small confined space, a lot of people. So it's not going to be easy. But maybe you can modify our lifestyle. It cannot be there through this difficult period to a sort of 10 to 6 and the routine that you used to have. Maybe that we need to go out at a different time, that we don't interact with too many people and still maintain physical activity. Fellows and colleagues at the Brompton know that we care a lot about being slim and athletic. It's not about the appearance, it's about the benefits that brings in terms of immune system, in terms of arrhythmic propensity, in terms of mental and physical well-being. If there is an opportunity to give up smoking, this is the one. We need to improve our diet and optimize our weight through this difficult period. And maybe there is time, we've never had this time, to do something different. Maybe take up a hobby, arts and crafts, read a book, and take better care of ourselves and others. You've seen these slides, colleagues who are working in the field, about how can we do better for congenital heart disease, because, as I said, we have a good framework here, but it's not tip-top. It's not what we should be aspiring to 21st century. And I'm hopeful that through this crisis, and when we survive it, and we will, that we come up at the other end better as peoples globally, but also our application of tertiary care for ACHD and other areas. And we must use and harness technology, not only the teleclinics which are running, and I can tell you, I'm having discussions with my colleagues, when this is all over, we'll be running in parallel to the conventional clinics, teleclinics, because they have merits, and some of the patients do prefer them. We must use artificial intelligence for risk stratifying patients. Remote monitoring is now here, must use it, and we must do a better job in terms of education. And again, we can use technology for this. So it is an unprecedented time. The storm is now coming to the United Kingdom. We are prepared to a large extent to face it. I think we need to be patient here. This is where I come from in Greece. It may be that it's not this summer. Maybe it's next summer. But I'm confident that we're going to weather this. And we need to stay at home until further notice. Still uncertainty, and needs to be decided when we're going to be, freeing some of these heavy measures. We need to stay healthy, strong, and together. And just to say that there is a lot of legitimate information on the web, starting from the Summer Foundation, that do a great job. I think your own provider, including the Brompton, and my colleagues and myself are trying to put into it as much information as it emerges. The British Congenital Cardiac Association, I think the American Congenital Heart Association, the NHS, and other legitimate sources to guide you through this difficult period. Thank you. So what we discussed